First of all, I want to thank Dr. Gottschalk so much for being with us today. This is the second time you have done a webinar with us. The first one was fabulous. And I know that this is going to be as well. It is such a hot topic, disrupting the progression of migraine in our lives. Dr. Gottschalk, welcome. We really appreciate having you here today.
Thank you, Shoshana. It is absolutely my pleasure to be here. I think you are doing wonderful things in this area, and it's my pleasure to talk about what I agree are really, really important themes that often get glossed over in practice. I will go ahead and share my slides. So I want to talk about migraine progression, which is in the formal sense referred to as migraine chronification. But that's just a label that we'll talk about that refers to the idea that migraine can progress, often progresses, and what we know about why that happens, how often that happens, and what we can do about it. This illustration on the initial slide is from the Wall Street Journal about a decade ago, and I love it because it does a great job, I think, of making some of the main points about this illness, namely it's a brain disease, it's not a blood vessel disorder, it's not an emotional problem, and that it affects many, many, many people, including a lot of kids, and that all of the symptoms that we recognize as related to migraine are easily localized in the brain. All of that makes it an important sort of change from the old model. But when we talk about migraine progression or chronification, the chronification term comes from the somewhat arbitrary decision about 20 years ago to define migraine as two main categories: episodic migraine, meaning headache less than 15 days a month, or chronic migraine, meaning more than half the time. Chronic migraine does not mean I've had migraine for a long time. It means I have migraine a lot of the time. And so when you move from the episodic category to the chronic category, we refer to that as chronification. Dawn Buse and Richard Lipton and others have done many, many studies over nearly 30 years now, which have looked at what do we understand about why some people get worse. And this slide from just a couple of years ago is a summary of some of that evidence. So in the green box, we say people who have other medical conditions are more likely to progress, like depression or anxiety or some other significant pain disorder, or who have obesity or asthma or snoring. Snoring, of course, is specifically related to the question of whether or not there's sleep apnea. But it's interesting that in the headache literature, even just the presence of snoring itself is a risk for getting worse. You don't necessarily have to have sleep apnea. Then in the gray box in the upper right, so-called exogenous factors, meaning things that happen to people, stressful life events, major stressful life events, head and neck injury, concussion, traumatic brain injury, whiplash, etc. And to some extent, use of caffeine, which mostly refers to very heavy use of caffeine. Then there are what I think in many ways are the most important factors in the red box, treatment related, meaning poor treatment efficacy. People who have treatments that don't really work are likely to get worse. It's that simple. And I think that is a concept that is not nearly well enough appreciated by patients or doctors a lot of the time. And then so-called medication overuse, which we'll talk about more in a moment, but I think that for all intents and purposes, the label medication overuse is really just another term for poor treatment efficacy. And there's some good evidence to support that view. It's certainly based on my experience. And then last but not least, headache features. So if you already have headache frequently, you are even more likely to get worse, not surprising. If you have frequent severe nausea with your attacks, that's an indicator that you have very bad attacks that are also likely to get worse. And if you develop during your attacks what we call allodynia, meaning at some point in an attack, usually hours into an attack, you move from just having pain to feeling pain from what would otherwise be normal stimuli. Somebody scratches you or touches you with something cold or puts pressure on part of your body, and suddenly that feeling becomes nasty when it normally wouldn't be. And that the presence of that feature with some attacks turns out to be a predictor of getting worse over time, because it says something about how long you've had migraine and how bad those are. Now, this slide from an important paper a few years ago is just to make the point that we should not get stuck with the idea that chronification is an irreversible thing, that once you have developed chronic migraine, that's the end of the line until somebody cures you. On the contrary, this slide simply makes the point that in the Cameo study, when people were followed over time, one of the questions was, what percent of people get worse over time and what percent of people can recover from chronic migraine? And what this slide says is people shift back and forth over time. That as you look at a cohort and then you check on them again 6 months later, a year and a half later, some of them have gotten better over time, and then some of them get worse again, and some of them get better. So this is a fluid issue. There are times when people meet criteria for chronic migraine more than half the time, and then there are times when it's less than that. And depending on how big the window is that you're looking at, that will change your estimate of how much of the time people have chronic migraine or what percent of people have chronic migraine. But that fluidity is really the point I'm trying to make, is a very important part of the picture, because that's exactly what we're trying to capitalize on with treatment, is if you have progressed to this point, what can we do to put you back in the other direction? And there turn out to be a few things that do help with that. And then one of the specific risk factors that I mentioned earlier about depression comes up over and over again in studies that have been done in this area, namely that a history of significant depression does become a major risk factor. Now, this is data from an earlier longitudinal study over a period of a few years, now 20 years ago, that said, if it's not just having depression, but if you have moderate depression, your risk of worsening is a little under twofold. Whereas if you have severe depression, it is more like 2.5 times more likely. So that's an important point. We don't understand that relationship. We don't understand what it's telling us about the biology of migraine or the biology of depression, or how those two go together. Some work is starting to be done in that area. And it's also important to note that in many of these studies, the definition of depression is not a clinical diagnosis of depression. It's severity of symptoms on a very simple screening tool like the Patient Health Questionnaire, or PHQ, which simply classifies how often you have felt hopeless, how often you felt like you can't get up and do anything. And that certainly are important features of depression, but may not only be that. So just to keep it in mind that whatever it is that we're picking up on that we call depression in these studies is important, but it's not entirely clear what those are. Now, moving on to this issue about so-called medication overuse, that some drugs seem to make people worse. Let's look at the best study about that idea that was done, again, almost 20 years ago now, by some of the stars of headache medicine, Ms. Marcelo Bigal and Richard Lipton and Ann Scher. And what they did was to look at a group of people with migraine over the period of a year and said, if we look at the main drug that you use to treat your attacks, does that have an effect on whether or not you get worse over time? So looking at this slide, in the bottom left corner, triptans, you see 3 lines. The orange line is saying at the beginning of the year, if you had up to 4 headache days a month and you use a triptan to treat those attacks, how likely is it that a year later you will have progressed to chronic migraine? And on this slide, or in this graph, it says very low risk. So if you don't have a lot of headaches and you use a triptan, you're in good shape. In the blue line, if you have between 5 and 9 attacks, so something like twice a week migraine, and you're using a triptan, the likelihood of progressing to chronic migraine is still low, on the order of 5 to 10%, but under 10. And then finally, the green line, if you already have almost migraine almost half the time to start with, and you use a triptan to treat those attacks, you have a much higher risk of progressing to chronic migraine a year later. Not shocking. Having a lot of headache already is a risk factor for getting worse. And triptan alone doesn't seem to prevent that. But the real point of this slide is the two parts on the right. So on the bottom right, this is showing the same relationship or the same question about relationship for NSAIDs. So those are over-the-counter anti-inflammatories, ibuprofen, naproxen or Aleve, even Excedrin. If those are your mainstay for treating a headache, what are the chances of getting worse? And the point here is, if you have up to 9 headache days a week and a month, and you use an NSAID, you have apparently no risk of getting worse over time. If anything, it's a guarantee that you won't get worse. And even at the highest frequency of baseline, you are starting with 10 or more headaches a month, then using an NSAID is a better option than a triptan. So that's the evidence that we have when someone asks the question, is there a relationship between what drug you use and whether or not you get worse? And the reason I highlight this study is this study says if there's anything you should do when you treat migraine, it's take an NSAID. And yet, every day in offices all over the country and the world, patients come in who have a lot of headaches, and their doctor says to them, oh my goodness, you're overusing Excedrin or ibuprofen or whatever, you need to cut that out. And the question that should come back to them is, says who? Because this study says that's not the problem. If you then move up to the upper left corner, you see that people who use an opiate, Tylenol with codeine, Fioricet with codeine, Percocet, any of those, have, relatively speaking, higher risk of progression at any level of migraine to start with, but clearly much more for the highest level group. And then the big, bad, scary one over here on the upper right is barbiturates. So that refers to Fiorinol and Fioricet. And what this graph says is, it doesn't matter how rarely you use a drug like Fioricet, using that drug raises your chance of progression to chronic migraine astronomically. So much so that for the green line, you can't even measure the risk. It goes off the chart, literally. So this, like many, many other studies around the world, says if there's one drug that no one should prescribe for migraine ever for any reason, it's a drug like Fioricet. It doesn't help. In fact, it makes things worse. Now, the idea of what you use is one simple question. This is just saying, here's a study looking at if people usually use this or that, where do they go in the future? Fine. And then the same group of researchers refined that question and said, well, what if we ask, how well does your treatment work? So this is the Migraine Treatment Optimization Questionnaire, or MTOQ, which consists of 4 questions. The first 2 questions are, is it true that when you take your acute migraine medicine, you are pain-free in 2 hours or less? And does that mean that you stay pain-free for the next day, that you don't get headache that bounces back? Keep in mind, these 2 questions are the FDA mandated outcome measures for clinical trials of acute migraine drugs and have been for 30 years. In other words, if you do a trial of Imitrex or Ubrelvy or whatever it is, and you want to show the FDA that this drug works better than a placebo, you have to show that people who get your drug are more likely to be pain-free in 2 hours or less and will stay that way for 24 hours. They now also include the most bothersome symptom. But these 2 questions are based on that idea of, well, if you're taking something that's supposed to help, does it actually produce this result? And I just want to point out that I ask these questions to people every day when I meet them for the first time. Here we go. You've treated migraine, you have chronic migraine, you've tried other therapies. Are these two things true? Because I want to be sure that that's true about your acute medicine. And most people say, well, that would be amazing, which makes me feel good. Okay, I will offer you something that now should do that. But sadly, it also means no one ever told them this before. Somehow, the idea that acute treatment is supposed to really, really work well is some kind of a secret for a lot of people. Apparently, a lot of prescribers don't understand this, and I don't know why they don't share their optimism that this is an achievable goal, but it clearly is. The other two questions on this questionnaire, this survey, are: does your current acute treatment mean that you're able to plan normal activities and that you feel in control of what you do? So those are quality of life measures. Do you feel good about your therapy and can rely on it so that you don't have to second guess yourself about whether or not you can go to dinner or have a party or go to your kid's event or whatever it is, that this acute treatment that you have keeps you safe? The other question that you could add, which is not part of the survey, of course, is have you been in the ER for a headache lately, which clearly means that you need more help with your acute therapy. But with all of that in mind, here's the point of asking those questions. It's not just about, I want you to have really good treatment. That's true. But the same AMPP trial used that tool to ask whether the results of that questionnaire predict the future. So looking at over 10,000 patients followed for 3 to 5 years, what they showed was if you have an awesome acute treatment, if you hit all 4 of those questions almost all the time, then your chance of getting worse each year to chronic migraine is about 2.5%. But if you answer those questions and say, it takes the edge off, you are 3 times more likely to get worse. So this important study says, doesn't matter what you use, what matters is the outcome. If what you use works well, you are very unlikely to get worse over time. But if what you use doesn't do that much, you are at risk for getting worse. So here's a graphic display of the same information. People who had the best possible response to their acute treatment had a small risk of progression. And when they had a lousy response to acute treatment, they were far more likely to get worse over time. So what that says is, if you say, yeah, my treatment kind of takes the edge off, what that's really saying is, I'm going to be worse in a year at least. And that's an important problem that we need to focus on. I think it's one of the most important problems in our field. Now, that idea that taking a treatment that really works well and that the idea that anti-inflammatories are bad is simply not true gets at this question of so-called medication overuse headache, that if you have a lot of headache and you take this medicine a lot, apparently that medicine is making you worse. Okay, that's a theory, but when we look at the data carefully, a few years ago, some of the same researchers in the group at Mass General, Dr. Scher, Loader, and Rizzoli, carefully reviewed all the evidence that we have about migraine getting worse and the type of medicine you use and treatment trials that try to deal with so-called MOH by detoxifying people, a lot of fancy, powerful words like that. And what they came up with was, hold on, frequent use of symptom-relieving medications should be viewed more neutrally as an indicator of poorly controlled headache and not invariably as a cause. So people are wedded to this idea that taking a lot of acute medicine will make you worse, when really what's, I think, a much more neutral and sensible view is, if you're taking this medicine a lot to treat your headache, apparently it's not working very well. Because if it worked well, you would take it and your headache would stop and you would be okay until the next one. That is exactly the model that I follow in terms of trying to help people get better. Here's an example of what we've seen over and over again in the trials of CGRP directed therapies for prevention. So this is one of the trials, galcanezumab or Emgality, which had in the trials people who had chronic migraine and who also qualified as having so-called medication overuse. So this is looking over a period of 6 months and saying, if you started out with this much headache and you were given either placebo or one of 2 doses of Emgality, what does that look like over time? And the top group is the group that did have so-called medication overuse, and the bottom group is the ones who don't. The point I'm trying to make here is look at the difference in the response. The gap between placebo and the treatment arm here is much bigger for people who had migraine and so-called medication overuse than for the ones who didn't. In other words, so-called medication overuse disappeared more often than the people who didn't have so-called medication overuse simply by giving them a good treatment. When I was trained in headache medicine, I was told initially, oh, you have to identify medication overuse because it is something that will prevent a response to preventive therapies. If people are medication overuse, they're in some kind of vicious cycle, and it will keep you from making them better. Not that that was based on any actual evidence. Whereas here you see a study that says, on the contrary, if you have a lot of headache and you're trying your hardest to treat it every time it happens, and suddenly you're given a really good preventive therapy, you are even more likely to get better than someone who's not doing that. I think that's a really, really important point about what we have. So that's some studies and slides that talk about whether or not it's true that a given type of medicine is a risk factor for getting worse. That's clearly true for one in particular, Fioricet. And it says that what really matters is how well your acute therapy works. That's the thing to focus on. And the last thing I want to touch on is a very important topic that is finally getting some real attention in our field, and that is about migraine-related stigma. So this is a graph from a study that was published just about a year ago, the Overcome study, which is sponsored by Lilly, and it is the largest study of migraine in this country's history. It's got over 50,000 patients in it at this point. And this is an analysis that looked specifically at the question of how does stigma relate to how well people are doing. So if you look at this black line in the center of this nest of curves here, you're asking the question, what's the relationship between how many days of headache you have a month and your migraine-specific quality of life, the so-called MSQ-RFR, which is a bunch of questions that ask how migraine affects your life on a day-to-day basis, and in particular, the questions that focus on how often does migraine keep you from being a good worker or being a good partner or being a good parent or any of those things. How often are you limited in what you can do based on migraine? So, not surprisingly, the black line says the more days of headache you have a month, the worse your quality of life in relation to migraine. Then they said, what if we look at the role of stigma in this relationship? So using a validated scale, the migraine-related stigma scale, which asks about how often do you experience this kind of discrimination, this kind of demeaning response to the fact that you have a migraine or talk about it. And stigma in this scale is broken down into 2 main themes, so-called minimizing burden, meaning, what do you mean you can't come to work because you got a headache? Come on, I get headaches. I still come to work. Why are you exaggerating this problem? It's not like headache is really a big deal, something like that. Or straight up secondary gain. In other words, you're lying. Yeah, right, you have a headache. In other words, you want to go play golf, or you got drunk last night and you're hungover, or you want to go to your kid's event and you're just saying you have a headache because it sounds better, whatever. Those 2 kinds of stigmatization occur all the time. And anybody with migraine, I think, can endorse they experience it at least some of the time. But this study specifically said, how much of the time do you deal with this? And does that have an influence on your overall quality of life? And the answer is clearly, oh boy, does it. So here you're saying, if you are somebody who's lucky enough to never experience migraine related stigma, your quality of life is better at any level of migraine frequency compared to people with bad stigma. People with bad stigma who experience both of these often are always worse off than somebody without stigma, so much so that you can draw a line here and saying, if you have 28 to 30 days of migraine a month and live in a compassionate environment, your quality of life is better than somebody with 2 days of migraine a month who lives in a stigmatizing environment. So if there is something else to focus on here besides which medicine you use in terms of how bad your problem is and how it affects you on a day-to-day basis, it is clearly something about dealing with stigma in society. And then I just want to touch on this really fascinating and powerful and unfortunately heavy study that was published this year, which looked at understanding the stigma of diseases in general. So these are some psychologists and sociologists who've been studying stigma for a long time. And they said, well, stigma can mean many things, right? There is your experience of stigma in society, which we just looked at. There is the notion of internalized stigma. How much do you embrace or endorse some of these ideas that migraine is somehow your fault, you're not living well enough, you're not trying hard enough, whatever. And you can ask people survey questions. But another way of thinking about stigma is when we look out there in the lay press, we look at newspaper articles, journals, whatever, when people talk about a disease, do they tend to talk about that disease in terms that are compassionate or in terms that are judgmental? And how different is that when you look at different diseases? So they took the entire LexisNexis database of everything that's been published over a period of 40 years and transcripts of TV newscasts about diseases and magazines like Newsweek and Time that mentioned a disease. They ended up with almost 5 million documents over that 40-year period. And then they said, anytime that one of 106 diseases is mentioned, what's the language around that? So they did what's called a proximity analysis, looking at the 30 words before and the 30 words after that disease, and said, is that positive or is it pejorative? And one of the comments they make in this is that a theme that exists in this area of study about stigma boils down to some notion that we all have of a just world hypothesis, meaning we've all been raised on some notion that if you are happy and healthy and doing well with no disease, it says something about the idea that you're living right, that you're doing things well. But if you are having a disease, if you're sick, it's somehow something that you're doing wrong. You're either a bad person or you're making bad choices. So the themes of stigma that come out of the literature, the press, are either about judgment or straight up disgust. In other words, either a disease is, hey, you are just not living right, you are a bad person, you make bad choices, or, oh my God, if I had that disease, I would not be able to show my face in public. That's just too gross to even think about. So here's the results of the study. This is looking specifically at the judgment score, and they broke it down into all these chronic medical diseases as opposed to infectious diseases, which we all have a sense are a little bit more judgy than regular diseases. And worst of all, of course, is psychiatric diseases. But this study says definitively for the first time that when you look at the way people talk about illness, look what's here. Migraine is the most stigmatized disease on the planet compared to anything you can think of. Alzheimer's, Parkinson's, ovarian cancer, lymphoma, chronic pulmonary disease, which is basically a reflection of smoking, obesity, heart disease, liver cancer, hypertension, you name it. Nothing is more heavily judged. Nothing is considered as immoral or a bad personality trait as migraine. It's on par with many infectious diseases. In fact, migraine is more heavily judged than HIV, malaria, tuberculosis, Lyme disease, and is as bad as many psychiatric diseases. The only ones that are worse are things like alcoholism, drug addiction, and depression, which, by the way, make people behave in a way that is viewed as scary or dangerous. And migraine is right up there with all of those. So I think that is enormously powerful information that out there in the world, this is what comes across when you look at the way people talk about an illness, that migraine is a clear reflection of your bad approach to living. And I think we all need to work really hard at figuring out how to change that perception, because it's nuts. And the idea that I treat this problem, which is the biggest cause of disability in the world and causes more time lost to disease than all other neurologic disease combined, whereas my colleagues who treat Parkinson's and MS and ALS and Alzheimer's are dealing with something that everybody agrees is something you should deal with compassionately, because it's terrible that you have this affliction, and what can we do to help you? And therefore has much more funding for research and everything else. So knowing that this is true says a lot about the way people around you are thinking. And the previous study says, if you experience stigma a lot, it is having a direct effect on the burden of your disease in day-to-day life. And that is something I think we need to understand much better and then figure out how to fix. So that's the slides that I had prepared for today, and I look forward to hearing some of your questions.
Yes, wonderful. Thank you so much. I really appreciated that, Dr. Gottschalk. Some of the, I mean, everything you said was just fascinating. Some of it was really super interesting, especially when you were talking about medication overuse headache and stigma, you know, and unfortunately the MOH has been used to create stigma for patients too often. And, you know, that's just really devastatingly sad, I think is the only way to put it. I have a couple of questions that I caught in the chat, but just want to remind people that I can't look at the chat right now that I'm back on. So if you have a question, please put it in the Q&A. Should be somewhere on your screen. If you're on your cell phone, you may not see that, but if you're on your computer, you should be able to. So a couple of the questions were, somebody asked if they use a different medication each day. I'm kind of imagining this is because the doctor has said you need to avoid MOH. But if I use a different acute medicine for each time I have an attack, does that reduce the chance of having medication overuse headache, or have no relationship to it at all?
It's a great question. And you're absolutely right that I think that's trying to work with this warning that so many doctors give of you're not allowed to use this drug more than 2 or 3 days a week. But if you have migraine 5 days a week, what are you supposed to do? Supposed to not treat some of them, just suffer? I mean, that seems to be the implication. So I think that's a creative way of dealing with this warning, right? Well, okay, so I'll use this one twice a week and a different one 2 or 3 days a week, and then I can say I don't overuse any one drug. There's no data here. No one has ever asked this question in a scientific way. Does doing that better than just using the same drug every day of the week or every time you have a headache? But I think a useful answer there is it goes back to the study about the MTOC, the migraine treatment optimization. Right. As long as it's true that whichever choice you make works really well, that each time you get a headache, you can snuff it out fast and it doesn't come back, I don't really care what you use. And that freedom to say to people, what we need to do is give you some tools so that you can figure out what works best, because it won't always be the same answer. You wake up with a raging headache, you clearly need something that works fast and well. You have a mild headache.
We just had an issue with internet, that's all, but you're back on.
Sorry. If you have a headache that's just starting in the middle of the day.
It looks like not. We have an issue with the internet right now. Hopefully Dr. Gottschalk will come back on, or maybe it's just mine. This is my internet connection is unstable, which is never good. Okay, we're back. I think we're back, Dr. Gottschalk. We just had an
Okay,
internet issue. I
no
just lost the
problem.
last couple of sentences. That was all.
Well, so I was just saying that for my purposes, the bottom line is as long as what you're using is working well, then it's a matter of you get a toolbox of different options that you will figure out how to use depending on where you are in the phase of a given migraine, how bad it is at the moment, and what's the best tool to use so that you can get rid of it as fast as possible.
Absolutely. And that makes a lot of sense. It kind of leads me into one of the questions that someone asked before this event. And that is, what role might the migraine action plan play in helping reduce the risk of progression? And I sent you an example of the migraine action plan that my organization's created that we're going to try to get out, where basically, for those people who don't know, it's not just you walk into the doctor, he gives you one medication or one treatment and you're out, but it's what do you do if this happens? And then if that doesn't work, what do you do with that? How important do you think it is for patients to have a holistic migraine action plan rather than just one treatment option?
I think it's the single most important thing that somebody should come away with from a consultation with a headache specialist or whoever's treating your migraine. This is the key, is that you need, because we know for sure for any given patients, migraine exists on a spectrum. You have mild days that you might call tension type. You have raging days that everybody would call a terrible migraine. You have ones that shift from mild to severe gradually. You have others that you wake up with and they're full blown. Each of those needs a different answer. And it's almost always true that you can take a certain treatment and most of the time it works pretty well, but sometimes it gets away from you. And then what? So having resources to deal with each of these situations, each of the flavor or characteristic of your headaches is important. And along those lines, I will just emphasize that the prodrome study from a couple of years ago has dramatically changed my conversation with patients. Now we have a study that says, hey, if you can identify your prodrome symptoms, if you notice that when I feel irritable and wiped out like this, or lights are bothering me and I'm having trouble concentrating, that I'm very likely to have a migraine later today, you can take ubrogepant and you're half as likely to even get a headache. That is a completely different conversation from what we've had up to now, that you got to wait till the headache starts to intervene. Now we can say you can treat in prodrome, you can treat in the headache phase, you can figure out what will make it less likely to have bad postdrome symptoms. That approach to that migraine is much more than just the stuff that we call headache symptoms at its peak is, I think, a very useful way to help people think about knowing where they are.
Frozen. Okay. We're having some internet issues today, but I think what you said is just it's so important that people don't just have one treatment and then leave their doctor's appointment. That is not the best way forward, as I could put it. Just for people who are here today, we have a migraine action plan that you can download for free from our website. So if Lorraine could maybe put that link up, if you go to our Toolbox page, it will pop up and gives you the opportunity just to get that. And then you can fill out what your part of it and then take it into your doctor and ask them to help you complete the rest. So hopefully that will be helpful to you. We do have some questions here today that came in and I want to get to them. And again, I do apologize for the internet glitching. No clue why it's happening, but that's just technology. So Heidi asked a question, has the AHS or IHS released a position statement about the importance of effective and early treatment to avoid chronification?
That's an excellent question. I don't think that either has actually produced a position paper that specifically addresses that idea. The guidelines for treatment, updated guidelines for treatment from last year from the AHS, talk about when people should be considered for prevention and some things about the level of disability and that CGRPs should be considered first line. But I don't think we have a clear statement about the importance of that. And I think that's worth looking at.
Yeah, absolutely. That would seem like it's really important to have. So another question here from Liz Baker. She says, she talks about some of the treatments she took, but then she's asking, what does the data look like following a cohort over time with changes in migraine frequency while using preventives?
So we don't really have a lot of good information there, right? What we have are unfortunately, relatively short-term studies of prevention. Typically, for episodic migraine, the window is about 6 months of treatment versus placebo. For chronic migraine, it's even shorter, about 3 months. And then many of those studies will convert people into the so-called open label extension of a trial where, okay, you've been in the section where you were blinded and nobody knew if you were getting drug or placebo. Now that we've got those data, everybody gets the treatment, and we want to see how people do over a few years. That's somewhat useful information, but really what it's about is safety. Is there any concern that after a year or two or three, there are new problems? Fortunately, we haven't seen that yet. But as far as whether that means that people will do even better over time, you can't really say much, because all that you're really looking at is people who stay on the treatment tend to do pretty well because they like it and it's working. And so they will, but if they drop out because it's not working, you lose that information. So a really important question. That's part of what the AMPP study or the Overcome study is trying to do better, is say, if we look at just a whole group of people with actual migraine in the real world, what's the relationship of their preventive treatment and their frequency and the severity and what acute treatments they work? And can we start to tease apart which of those matters most? But we don't have a solid answer to that yet.
Right, absolutely. Well, obviously, it's such an ongoing disease, right, in terms of research and studies and what's most important, and so many changes in the last 10 to 20 years. It's, if I think about what it was like when I was a young child, and then even in college, there was nothing. You could take pain medication, and that was it. And you kind of tried to get on with your life as best you could. Now it's completely different, but it's so concerning. There's so many treatment options, but patients still are not getting the message that they need to get, that, you know, this is a disease that can chronify, it can get worse. So a couple more questions here. I know some people are asking questions specifically about treatment options for them, what they can do. We're not going to answer those on this particular event. I would encourage you to go to our website, take a look at the Migraine Toolbox. That is also downloadable. And we do have some previous videos about that. There's also a couple of questions specifically on THC, which unfortunately we probably will not have a chance to get to, but we are considering actually doing a live event on THC and CBD. So hopefully we can take that. So one question here, following up on what you said about Ubrelvy, ubrogepant being used during prodrome, is how often can Ubrelvy be taken?
Well, the information we have right now is that you can use it up to twice a day. That's what was done in the trials, and we know that that's safe and that a second dose can be effective when the first one didn't quite do it. But what we don't really know, just because we don't have studies that looked at this, is could you use it every day? Maybe. I have no concerns about the safety of doing that, and I understand that there is a trial in progress looking specifically at ubrogepant as a preventive drug. So the fact that they're even doing that study is reassuring that that appears to be a safe option. And is it as good as atogepant or rimegepant or whatever? We'll find out. But the practical answer, of course, is depends on how many doses your insurance will let you have. Is that 8 a month? Is it 16 a month? But it won't be more than that. So you still have to pick and choose when you have frequent attacks.
Right, absolutely. That makes sense. And also, even if we see that it is safe to take it every day, then it has to get to the point where insurance is going to cover that as well, rather than just covering a few pills.
Right.
So going back to where you talked about allodynia, and I believe you're talking about allodynia during attacks as being one of the signs that the disease may be progressing. Is it only during attacks, or is it also in between attacks?
It is also in between, but those have been asked in different ways. But it is true that people who meet criteria for chronic migraine are much more likely to have allodynia between attacks, for sure.
Right.
What exactly that relationship is there a way to address that particular part? Are there some medications that are better than others? Maybe. There's some recent studies that have looked at the CGRP drugs that say it does seem like over time a CGRP preventive will reduce your average level of allodynia. Good sign, but it's not a black and white answer yet.
Right, absolutely. So another question we got actually before this event is just asking, you know, are there likely to be certain phenotypes or extensive family histories, which are more likely to chronify? I mean, that's just basically asking, are there different phenotypes of migraine that respond in different ways?
So that person is either secretly a migraine researcher or should be, because that's exactly the right way to ask the question. And that's what some of that stuff on the first slide I showed was, that the data from these various studies have said, well, yes, if you have attacks that are frequent and have a lot of nausea, or you have allodynia, those are phenotypes that predict worsening. If you are a person with migraine who also has snoring or obesity or asthma or severe depression, you are more likely to get worse. But that is just sort of scratching the surface, right? We don't have any kind of genetic markers that are good predictors of this. There's a little bit of that starting to happen. And are there better ways of slicing the pie in terms of a combination of features that predict worsening or improvement? We're waiting to get those results.
Right, that makes sense. It'll be really fascinating when we get there, hopefully in my lifetime, because personally I'd be fascinated by that. So we have a question here about stigma. They say, this is from Lisa. She says, do you notice stigma among other medical providers who don't have a focus on headache medicine specifically?
I appreciate that question very much. That issue is so common that in the headache medicine space, we refer to it as courtesy stigma, that we, the headache providers, are stigmatized just as much as our patients. And that comes out in every imaginable form of, why do you bother treating headache? Like, ew, that's just a waste of time. I treat a real disease and I make people better. Why don't you make that choice? Happens every single day.
Interesting. That's interesting. Okay, let's talk about obesity. I think you may have covered it or maybe not during your talk, but a lot of the times part of the stigma that we face as patients is as the disease chronifies, a lot of the times weight gain will come on. And so I wonder if you could just speak to, I know that there are some studies that say that obesity is a risk factor for chronification of migraine. And yet anyone who has migraine severely will know that it's easy to gain weight because of medication and not being able to exercise. Maybe you could speak into that for a moment.
Well, no, that's so right there. That is absolutely the foundation. Is, keep in mind that the purpose of science is to address the question that causation and correlation are not the same. That just because two things happen often together
Right.
doesn't tell you why. It just says there's information there. So what you just said is exactly the point, that it is just as likely that having chronic migraine leads to obesity as it is the other way around. And we don't yet have large longitudinal prospective studies that say, is it true that if you have obesity when you have episodic migraine, that you're more likely to get worse? Or is it just that when people get worse, they gain weight, which could just as well be true? So that is fundamental, but it's also an important source of bias, right? That is clearly part of the problem, that what a physician sees, usually a physician sees walking in the door, is somebody who has chronic migraine and they're depressed and they are overweight and all this other stuff. And the fundamental attribution bias, as it is called, says to most people seeing that picture, well, the problem isn't really headache. The problem is you're overweight and you're depressed. So go see somebody who can manage that. And that is not actually the data that we have at all. When you look at studies that just ask the question, how good a job do doctors do diagnosing migraine? We know it's pretty bad, but it is worse when somebody has chronic migraine. That still blows my mind. If you walk in the door with some migraine, you have about a 50-50 chance of getting the right diagnosis. You walk in the door with 20 days of migraine a month, you are less likely to get a diagnosis of migraine. What is that? Whatever it is terrible, but it's clearly getting in the way of good treatment.
Right, absolutely. And I think it gets in the way of patients being willing to be compliant, if you want to use that term, or even try new options because they're so stigmatized. You know, I know that in the past, there have been things I'm not going to tell my doctor because I don't want to be stigmatized. If I tell him I'm feeling down, I'm struggling with depression, I'm thinking he's going to say, well, you need to deal with your stress and then your migraine will get better. And we saw that in some of the comments we had before this event as well, that several people in our community have been told by their doctor that it was just their hormones. Obviously, it was the women, just your hormones, almost like, okay, so we can't treat it. And obviously more stigma there. You can see I'm getting passionate about this because there is so much stigma, and it's just really heartbreaking. And I do want to say to those people that were asking for specific treatment ideas, it's not that we don't care in any way, that we're not actually getting to that question. We actually do have some incredible resources for you, and we will send that to you after this by email. So I just want to tell you that you are heard. We are seeing what you're saying, and you're heard, and we know. I have a question here about symptom changes. Are symptom changes other than allodynia and depression, and I know there was a third one you gave, a warning sign that migraine is progressing? For example, greater sensitivity or visual changes, you're getting an aura that's changed, that type of thing, or even less responsive to medication? And that's kind of a long question.
No, that's a great question, though. So a couple of things that come to mind. It is true that in general, a migraine attack that's associated with aura is worse and harder to treat than without aura. There are good studies about that. That's certainly clinical experience, that if you have an aura, get your best tools ready, because chances are this is going to be a humdinger. And then the other two that frequently come up are something about, I get clusters of migraine, or some people think that that's what cluster headache means. And what that really is saying is, if I get a migraine, I tend to get a migraine for 2, 3, 4, 5, 6 days in a row. And that is absolutely, to me, the evidence that your acute treatment isn't working. Because if it was, you would treat it on day one. That's the end of the story. But if you take something and it makes you feel better, and then the next day you got to do it again, and then you take something and you keep bouncing back, that is really what rebound should mean. I do something, it goes down, and it bounces right back. All that's saying is whatever you did wasn't quite good enough.
Right, absolutely. So we just have time for a few more questions. If anybody else has a live question, please put it in the Q&A right now so that I can make sure we get to it. Other than that, I still have some on our list. So do you find generally that as someone's disease chronifies, as it gets worse, that they're more likely to have to use a combination of acute medications or a combination of preventive as opposed to just one option?
Yes, I do. In a general sense, I think that's correct. But I also think embedded in there is the problem of this notion that we have about step therapy as opposed to stratified therapy. So I think everybody with migraine, even if it's twice a year or twice a day, should have some combination of something like a triptan and an anti-inflammatory and a drug like Reglan and an injectable form. All of those should be available so that over time you can learn what's needed when. I don't think that we should start with, well, just start with one thing, and then if that's not working, we'll add a second, and then 5 years from now, maybe a third. That's a formula for failure. So yes, if you've gotten to the point where you have headaches 2 or 3 times a week, you should certainly have prevention, and you need really good acute treatment. But even if you have headache once in a blue moon, you should have something that works really well.
Right. Absolutely. That makes total sense. So this question is kind of off topic, but it's so important. So I'm going to ask you. So we're being asked, we know that there are incoming new medications. So that was the first question, is, are there any? We know that there are. What are the incoming new treatment options that you've heard of that you're most hopeful about, or which might hit the market first?
So the main category that we're all really excited about right now is the so-called PACAP trials. So another transmitter like CGRP that is housed in trigeminal neurons and some others is summarized as PACAP. And there's good evidence that, like you infuse PACAP into a migraine patient, it can trigger a migraine. Okay, so then blocking it looks like a good target. We have good safety trials already. We have some evidence that that's a good approach. And now we're waiting for the big so-called pivotal trials that say blocking PACAP can actually reduce the frequency of headache. Then the big question will be, well, does that mean some people respond to CGRP and some people respond to PACAP? Right. Hopefully that's true. Does that mean you can combine them and that you'll get an even better response? Hopefully that's safe and effective, all of that. And the other one is that the amazing laboratory of Dr. Masood Ashina at the Danish Headache Center, where they study migraine, including things that can trigger a migraine, drugs that will actually cause it. In the last several years, they've focused on potassium channel agents, that certain potassium channel blockers or activators are better at triggering migraine than anything they've ever studied. And so the suggestion there is if we can figure out a safe way to block those potassium channels, we should be able to help a whole new group of migraine patients that didn't get enough from our other treatments. That remains to be seen, but that's what we're holding out for.
Yeah. It's exciting. It's exciting that we have more options that are coming up. I did have a question here from Victor, wanted to know if this will be available on a recorded basis. Yes, this is recorded. It should be up on our YouTube channel by tomorrow, and we'll send an email out to everybody who registered. So I'm looking at the clock, and we literally only have like 3-4 minutes left, but I have a couple of questions. So let's see if we can get through them. Based on the factors that you've already mentioned, do you think it is possible to prevent or reduce the risk of migraine becoming chronic? Let's just say, is it like for everybody, is it possible to prevent migraine chronifying, or we still need new treatment options for that?
Well, I absolutely believe it is. That's how I run my practice. But we don't have long-term studies that prove that that's true, or even that tell us if some things are better than others. That would take a large number of people studied for 5 or 10 years. That's not something that the NIH has been willing to fund yet, but in my practice, it is absolutely that. It's saying, if I'm lucky enough to see somebody who only has episodic migraine, I want you to have optimally effective therapy today so that you don't get worse, because all the evidence we have says if you're having bad attacks and they last a long time and they disable you on a regular basis, you're going to get worse.
Right, right. Now, what about the people, probably should have asked this question earlier, but what about people, including myself, who have had chronic migraine for so long, especially people who, you know, when we were children, there were no treatment options and nobody understood about migraine disease. You know, is it still possible to reverse that for people such as myself? And I'm just going to say that during the Migraine World Summit, there was a speaker and her who talked about this, and her estimate was that about 40% of people with chronic migraine, so 15 plus days a month, can reverse that progression. But that immediately made me think, well, that means 60% can't. That's kind of exciting numbers, but also devastating numbers.
Right. And I'm biased because I'm talking about my reflection on my own practice, but I would say in my practice, the numbers are better than that. I would say that well over half the patients I see who have chronic migraine initially get back to low frequency episodic. And that's by using all the tools we have. It's, yes, you need good prevention. We might need to combine Botox and CGRP or whatever, Nerivio, it doesn't matter. And we need to make sure that you have an acute treatment that will actually turn things off. So part of our model of chronic migraine is you have developed chronic sensitization. Your nerves have been irritated and activated so many times that they now live in that state, and it doesn't take much to tip you over into another bad attack. So how do we reverse sensitization? That's something we try to do in practice by using good tools, but we don't have good scientific tools that can measure sensitization and what things could potentially reverse it faster. That's the holy grail right there.
Absolutely, absolutely. Well, we are out of time. I'm about to give you the last word, Dr. Gottschalk, but before I do that, I do want to thank our industry partner, Lundbeck, for helping us launch this educational project that is so important. Of course, really grateful to you, Dr. Gottschalk, for your time and just fascinating information. Really appreciate you. To everybody who's watching today, we hear you, we see you. Please come on our website. We have a lot of resources there. We will send that out by email. And if something is not working, I'm seeing some comments that things aren't working in terms of downloading, we will make sure that you get those resources. Again, this is being recorded. It'll be on our YouTube channel by tomorrow. So thank you so much for watching us and listening to this. Last word, Dr. Gottschalk, is there anything we've missed, or what is most important?
I don't think we've missed a thing. I think it's just to summarize that it's really just to say to people, don't settle for too little, right? The biggest problem we face is that people think that whatever they have is as good as it gets. And yet we know that there are actually really effective tools out there that are being underutilized, and that people don't know even what the definition of a good response is. So inform yourselves. It is possible to get better. There are treatments that can give you control of your attacks and make you better, but you need to push people to explore all of those options to get as much out of it as you can.
Absolutely. Thank you so much for that. And take care, everybody. It's been a pleasure.